All right. Well, good morning, everybody. So glad to see you here in this breakout concurrent session. My name is Roda, and I'm going to be convening this particular session and making sure that we stay on time. And we want to make sure that you online and those of you that are here have an opportunity to dialogue with our two presenters. So this is a session titled Trauma-Informed Care, Lessons from Early Childhood and Implications for Clinical Practice. And so we have with us this morning two amazing individuals who've done a lot of work in this space. This is Dr. Jimmy Venza and Dr. Beverly Beckles. And so I'd like to just give a little bit of an intro to who they are, and then we can go ahead and get started. So Dr. Jimmy Venza is the executive director of Adventist Healthcare's Lurie Center for Children and Social and Emotional Wellness. And he's done a lot of work in this particular area, having joined the Lurie Center quite a number of years ago in 2003. It's been 20 years. 20 years. Wow. And really is just very passionate about working with children and parents and family systems and the diversity of the families that are present there at the Lurie Center just really brings a depth of not only experience, but intervention. And so he works with and leads a team in providing services for those from diverse ethnic and socioeconomic populations, often dealing with trauma, abuse, crisis management, and a wide range of health issues. And so I asked Dr. Venza what gets him up in the morning, what excites him about the space in which he works in. And he said, the child-parent professional collaboration and journeying together, growing together, and healing together is what really gets him up in the morning. Our next presenter after Dr. Venza is Dr. Beverly Beckles, who is Dean of the School of Behavioral Health at Loma Linda University and Loma Linda University Health Vice President for Behavioral Health Education and Chair of the Department of Social Work and Social Ecology. That is quite a mouthful. But the bottom line is that she leads the behavioral health trauma team that has really responded to many of the natural disasters and conflicts around the world. In a matter of fact, over 60 countries. And I'm going to just name some of these situations and events that your team, Dr. Beckles, has been involved in. And I think many of you will recognize just the devastating situations that these natural disasters and conflicts have resulted in. Of course, there's the 2005 tsunami, Hurricane Katrina, earthquakes in China, the aftermath of the civil war in Cote d'Ivoire in Africa, the military conflicts that actually are continuing on now in Ukraine, Sierra Leone, the Ebola crisis, the list goes on. And her team provide support for survivors and employees directly impacted by these situations. And so I asked Dr. Beckles what gets her up in the morning. And she says the students and the opportunity to pour into students, the opportunity to learn together, and the opportunity to see their transformation. So without further ado, let's go ahead and turn this over to our esteemed presenters. And for those of you that are online, please feel free to go ahead and put your questions in the chat. And after their presentations, then we will have an opportunity to have some dialogue and some of your questions.
Thank you so much, Anne, and welcome to everyone in the room and all those online too. So we're grateful, Dr. Buckles and I. You'll hear a little bit about our intertwined work together, and we're reunited here after more than a decade. So that's a amazingly powerful story, which I'll share a little bit today. One of the things I wanted to highlight is when folks say, well, what is a Laurie Center? What is that? We're based just outside of Washington, D.C. We're part of Adventist Healthcare, and we are really focused on infant and early childhood mental health. So we have a couple locations just outside Washington, in Maryland. And for those in pediatrics or world of child development, this is a person you will recognize, so Dr. T. Barry Brazelton. So we have quite an incredible history. We were founded by Dr. Reginald S. Laurie, who's the father of child psychiatry, Stanley Greenspan, who was at National Institute for Mental Health, and Dr. Brazelton, who for a long time, for 99 years and 10 months, maybe not all of that time, he was at the Brazelton Touchpoint Center at Harvard, but for most of that time. So they got together 40 plus years ago and said, let's move away from the hospitals, let's move away from the major research institutions, and let's go in community and bring that research and training available to those who usually don't have access to care. And so the whole focus is on early childhood mental health, or what also we refer to as social emotional development of infants, young children, and of course their families. And so the center became part of Adventist Healthcare in 2006, and we're now over 160 professionals. So that's social workers, teachers, educators, home visitors, all working, as Anne mentioned, with one goal, extending God's care, and we do that through one family growing together. So that's child, parent, professional. So one of the things that I'll thread through today is, this will be a little sneak peek into early childhood as a way to think about how we support healthcare workers and how we support people who are in the field and facing increasing levels of stress and trauma. The center's work really is in the forefront for all these years. I should say it's been in the background for all these years and now is in the forefront. COVID really raised the level of focus on infant and early childhood mental health. Actually described as a crisis, as a catastrophe by the leading institutions, the Surgeon General, even a whole advisory report on what we need to do to make a difference in the lives of kids really suffering. The statistics that are coming out now and throughout COVID just really magnified what was already a mental health crisis in early childhood, especially around trauma. Folks here at Loma Linda University and Adventist healthcare systems across the country, and you go to your emergency rooms and you talk to the physicians there, and they'll all tell you the same story, which is a huge uptick in children birth, actually from 5 to 11 in particular, in the emergency rooms for self-harm, for overwhelming stress, and trying to hurt others. So that is just across the country. When you talk about the caregivers and supporters of those kids, right, especially when you think early childhood development, it's so intertwined to the caregiver's development. So it won't come as a surprise for you mothers here who felt more of the stress of COVID, that is just the percentage of families and mothers actually saying, so 70% is one of the statistics. Literally saying that the worry has negatively impacted my own health. And so we know developmentally what that means for kids. So one way to frame a place like the Laurie Center is focusing on early childhood intervention, especially mental health, is really a vaccine for early childhood trauma. We know actually how trauma affects young children and parents, adults, all of us. And we also know now, thanks to the research, how to help. how to make a difference when those things happen. So that trauma does not define the child or the teenager or the parent, that actually resiliency helps define that, and that there's a full life to live through those experiences. And I think in particular, over the last 3 years, the impact on the healthcare workforce, that's part of why we're here today, and you're going to hear Bev talk a lot about that, is really how we support a workforce to work under really stressful conditions, and to do it well and to succeed long term. So just to give a sense of what you'll hear from me is seated in clinical experience and research over 40 years. So in a sense, Laurie Center has 600 families who are receiving fully intensive services of intervention. So difficult stuff have happened, you know. As Reg used to like to say, teenagers just don't pop up with depression, anxiety, mood issues. Those things, those threads are all there early in life. And sometimes they burst forth at 18 months, at 2 years, and at 3 years. And those are the families who we work with in long-term care. And so we have several programs, both kind of integrated therapeutic and educational programs, and then specifically clinic work as well. Key to what we're talking about today is how we come about the work. So we're talking kind of trauma-informed as kind of the umbrella for today. So the principles of Laurie Center are, it's a relationship model. So it's a funny little word, attachment, which we'll talk a little bit about today. So attachment-centered, trauma-informed, and now better than ever in the last few years is equity advancing, has taken the same place with these other kind of principles, and then team-based care. That model of how we work with kids is really how we work as a healthcare workforce as well. That those same principles that we're going to talk about really translate well, and are powerful for how we design systems of care. Another aspect of Laurie Center, which really comes forward, is the training. So I was a postdoc in clinical psychology, 20 years ago at Laurie Center. So I was trained in early childhood and infant mental health work as part of Laurie Center. And so we've talked about that as that's a tradition that we carry. And we have folks who are with us all year long in training and how to do this work and how to do it well. When in fact, what you're saying to someone, a 22-year-old or 30-year-old or 40-year-old, welcome to the Laurie Center, where you're actually going to be threatened in your daily work. You could actually get hurt every day. In some cases physically, and some programs are working with the most intense acuity, in other ways emotionally. And emotionally with, you know, sitting with someone who is under such stress that they are contemplating harming themselves or burst out and harm others, and we're saying this is going to be your work, right? So how do we design a way to support that person in doing it long term and doing it well? So that's some of the principles today. Over the last decade, we have full research programs, empirical studies, and great outcomes in all our programs. So whether it's education-based, kind of integrated mental health and education, or just clinic-based, in terms of what helps kids grow and helps their families grow and what gets in the way. And that's very much a tradition of Laurie Center, because we were founded as a National Institute for Mental Health Research Studies. So that was actually the first 6 years of Laurie Center was this research, which the few other places around the country really laid the bedrock for how we think of infant mental health care. So we're benefiting from that from today's discussion. A couple highlights of that research is this funny little word of dosage, but if you're in the world of research, that sounds familiar to you, is the more treatment, when things have really gone difficult for a kid or family, the more support they have, the better. And the research bears that out. And the earlier it can get to the child and family, the better the long-term trajectory can be. And I think the last one, which we'll talk about, is that the importance, and this is the importance of the parent-child relationship or attachment relationship, the teacher-student relationship, and in some case here, the healthcare worker relationship, that those are unique caregiving relationships with have a specific function for human beings, and provide the opportunity for us to really support resilience and growth. So for those of you who know this so well, pardon, I'm just going to take a quick step about attachment so we level set. But if you're in the room, if you can just, you can actually, if you're online too, you can raise your hand. But if you just raise your hand in terms of like who's in regular thinks of attachment, talks about attachment in their day-to-day work. All right. So thank you. Wonderful. So attachment is something very specific, right? It's a relationship that we have, that all of us have. It's universal. Can't not have it. We're born with it. And that is when you are stressed, when you're an infant and you're stressed, there is a stressor. Something happens to that infant, automatic. You cannot help it, but you are going to move toward an established caregiver, usually the mother, father, aunt, uncle, grandparent, in order to make contact with that caregiver to reduce your stress. Right? And so this stress move toward, it is usually when you're infants, right? It's touch. You know, your baby cries, baby fusses, activates the caregiver comes and then, you know, rocks, soothes, coos, talks in a wonderful voice. The baby regulates. So this is how the baby ends up having an experience of safety and trust, communicates out, and has a positive response. So this is a really important, when we think of how to design systems. How do you support someone who's going to be under stress? This is the most important variable, is they have to have someone who they can go to as an adult or as a young professional who they can talk to, right? Who can help them regulate, calm down, think of different ways of maybe doing the work, creativity, all these wonderful things happen because actually the nervous system can relax enough. So you'll see that in lots of different ways. This is a great model. So if you're really into this already, just go online and go circlesecurityinternational.org. So Circle Security were 3 clinicians who traveled for 40 years, and they studied with all the specialists in child development. And they come up with this really elegant model, Circle Security. And so in brief, right, this is developmental science in like 20 seconds. So you have the parent's hands, right? And the child can be on the top part of the circle or the bottom part of the circle. All of life can be experienced in this. Very elegant. And that is, on the top part, the child is free to explore, to go learn, right? And that's supported, when it's going well, that's supported by the parent. Support exploration. And, you know, watch over the child, cheer them on. You know, if they're going up that step for the first time or third time and you cheer them on, go on. Help them, enjoy them. You know? And then the child gets stressed, right? New things. So then the child swings to the bottom half. And the child is scared, or the child needs to eat, can't access food yet without the help of the parent. So then the parent's role becomes that of protecting, right? Protecting the child, welcoming the child back, comforting, organizing the child's emotions. I can see you're really upset, and let's talk about it. Sit on my knee. Let's get some comfort. All that. Then that, right? That regulates the child again, and the child can go back up on the circle and go explore and learn. So welcome to grad school, right? Welcome to professional life, workforce. When we're doing our work, we're on the top part of the circle. And when things get really stressful at work, we're on the bottom part, and we need folks to help support us. Really simple model, but we can really unpack that all day long. But we won't. We'll keep going. So one of the things is then, when you think early childhood mental health, you think supporting workforce, right? Is how do you do that? You just got to support the helpers who are supporting kids. And so actually, Lori Center, it happens that this week is Mental Health Month. The month is Mental Health Awareness Month. This week and May 11th particularly is Children's Mental Health Day, National Children's Mental Health Day. So we're doing a virtual conference and really focusing on the helpers. How do we help the helpers help the kids? That's the pathway forward. Okay, so I'm gonna break off and I'm gonna show just a very clip. It's an old clip of a research study, which is just gonna really hopefully just give you a little punch, and a positive punch, an impression of how we as human beings rely on that social connection.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
Are you my good girl? Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that.
Okay, so imaginations, right? We're with kids, play therapy, we're working imaginations. So that is a patient, teenager, adult, just looks like a baby right now. Right? Here's the healthcare worker. Right? Right? So just let that, as you hear more.
It's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly.
We could just spend all day unpacking that. So that's in a relationship that's going well. That's with the child that, as far as anyone knows, doesn't have trauma. Right? Is you can maximally stress us as human beings by not attending to our needs. So for those involved in training healthcare workers, I mean, you could use that video and you could really do a wonderful job of, when you think of the welcoming people to the hospital or to the clinic, in the waiting room, what the emergency room is designed like. That has implications for all of that. Leaving someone without social cues about what's happening in a situation where they need to know, and unlike this infant, is already under stress, is really helpful in terms of designing programs. So that emotional attunement is really critical of parents, of teachers, of healthcare workers. And the emotional attunement to many of the people who come through the clinic doors or hospital doors, who maybe don't have high levels of trauma, is very different than folks who do have high levels of trauma. So that's another layer that really makes it complicated in terms of how best to practice. So that's what we'll talk about a little bit. But again, this is going to be impressional because this is like trauma-informed care. Like we could do months on this. But just to pause, right? So we heard that little distress and we got a little uncomfortable even with the baby getting distressed. Well, we're talking about a whole nother level of distress when we're talking about trauma, right? So the word trauma and Dr. Buckles will share this too, right? That's just a word, but what it really means is really horrible things, and horrible things happening to people, and then happening sometimes to us as in our own lives as well. So SAMHSA and other groups of, so if you really want to go in full, there are models at which every level of your system, from policy to all levels of practice, assessment, take a trauma-informed lens. And that certainly we're moving in that direction. Legislatures, and Maryland has a trauma-informed commission. Tennessee's already adopted actually one of the most far-facing trauma approaches as a legislature, and how all child care systems take that approach. So it's just that's there to lots of resources to look through. I'm going to take a little bit more just close to home in terms of what we see at Laurie Center and what the children and parents and professionals we have shared with us. And one key thing is trauma. When you think trauma, that's not them. That's not someone else we're talking about, team. That's us, actually. So it turns out when they do the trauma research, almost all of us have an adverse early childhood experience. May not raise to the level of trauma that others have, but have had adversity. And when we're welcoming, and they're gonna flow more of those folks because they have more of it. They're gonna have more medical challenges. They're flowing into clinics and healthcare. So this is the folks who we're going to be seeing in our hospitals and clinics. And it turns out this is also us as healthcare workers. So that's two directional supports that we need to think about in terms of designing programs, right? Both for the employee and also for the patient and child and family. So this is just a stat there. So for those who know ACEs, adverse childhood experiences, there's a whole body of research which has changed public health forever in this country, really identifying this, and you'll see, basically started out with 10 items of adverse experiences you could have as a child. These were adults at Kaiser down in San Diego reporting the things they had experienced early on in life: divorce, substance abuse in the family, and then it goes on to more difficult things: abuse and neglect in the family, mental health issue in the family. Just a rating of 10 of those. And so already a quarter of us have that by age 4, but most of us have it by age 18, at least one. Now, why is this important? Well, if you have 4 or more, turns out what the data shows is life changes, trajectory changes. So literally the five of the top 10 causes of death are based on early childhood trauma, right? Not like only the mental health things you think about, right? But heart disease, right? We have these wonderful cancer centers here at Loma Linda, right? Flagship, all these amazing programs, liver disease. This all stems from early childhood trauma. A great majority of impact is that. And so much so that actually, 20 years less of living when you have 4 or more of these. So when you think public health and where intervention from a hospital system should be and community system, it's adverse childhood experiences. That's what this story is about. I love this. So Peter Fonagy, who's just an amazing contributor to our understanding of mental health, especially in infants, his Anna Freud Center in London. So he was down presenting, and this comes out of the ACEs research as well, and they just see this all over the globe, but attributable risk. So all these things like, diabetes, asthma, these are the percentages that trauma is impacting that, right? So if we can address trauma, you're addressing a certain percentage of all these factors. So really powerful data. It's ongoing, CDC, all the data's there, and really accessible. Okay, so from a little bit high level to maybe just a little more personal level and sharing more experiences, folks. So, again, the caveat is we know in the room there's folks who have trauma. There's folks who had adverse experiences. So we just, if things get upsetting or you find upsetting, make sure you're taking care of yourself, taking a break. Anyone can go off and, go take some food, go for a walk, these type of things. And one of the particular challenges of trauma is it shapes how you see things and how you experience things. So because things happen to you, you see things in a different way than you would. And sometimes that's a big help. It actually saves your life because you assess situations more quickly and you can protect yourself. And other situations, it really complicates things. Like when you're in a preschool and there's actually not a danger, but you're experiencing it as a danger. What happens? So this is a child, about 7-year-old, who drew his heart. A long experience of very difficult threat to the child, needing to actually not live with birth parents in foster care, and in a really stable foster care, but it took a long time to get there. So this is his heart. Now this is later. This is not in the middle of it, right? This is 3 years of therapy, and then actually can draw something, can put it into some form and shape as opposed to just behavior. But loss, you can see loss is the overriding, and then there's a God kind of. It's thick, and so he said it's the loss is too thick. God can't even get in my heart. So we'll see what that looks like. So just real quickly, what is trauma as a particular thing? It's an overwhelming experience of danger, of threat, and it overwhelms the child's our capacity, right? It's not just a child, it's a parent's capacity. It's an adult capacity to regulate, to use the wonderful thinking parts of the brain, and to regulate on the limbic system side, the emotional part, and then organized behavior. So for those of you know, Congressman Raskin, who's Laurie Center's in his jurisdiction, and he experienced and his wife experienced a loss, the death of his son through suicide. He spoke about 2 years ago at one of our events, and it had happened about 2 months before. And what he said is children should never have to experience this, but adults should never have to experience this. It's too overwhelming for me. Yeah, that's what he said. right? So why this is so important to come together multidisciplinary wise and find ways to design programs to support team members. I'm going to move pretty quickly through a number of slides because I think you'll, like probably Dr. Buckles and I, we prepared for like a 2-day seminar. But it's just so the work is so important. So I'm just going to highlight a few things as we go through. But one thing is the sensitivity to cues, and it's relational, right? Trauma is always relational. It could be that let's say that in the case the parent is the threat, harms the child, or is the protector of the child. So a natural disaster or a threat from an outside the family, the parent then functions as protector. It's always relational. So when a person appears in a clinic or in the hospital, they're coming with an experience of a historical experience of how they expect to be treated. And so that will get played out. So that's really important for the team at the hospital to understand. And it triggers, right? The trauma triggers. It makes them so sensitive to trauma triggers. So that we'll talk about some more kind of specific examples of that. It's also trauma is so overwhelming, right? It goes beyond the verbal system. So you can have trauma as adult, but even though you're wonderfully verbal, but it's gonna bypass that. And of course, in kids, the trauma is happening pre-language, so they don't even have language yet, and trauma is happening. So you have an 18-month-old who's exposed to domestic violence. The yelling, the screaming, the sound of hitting. If we want to go into more detail, we can, because that child's experiencing all that. And so then now how does that shape the child's ability to see what's around them? Well, it makes them really attuned, very hypervigilant. Their nervous system is always high. That has lots of repercussions as well. These you can always think of in terms of care when people are coming into our clinics and hospitals. Facial expressions, really key. Eye contact, right? This is all pre-verbal. So you can welcome someone who's in some distress, and depending on you might be saying all the right things, but if your eyes are doing something else or your facial expression is doing something else, that's going to register with that person. And it's going to trigger. Right? So in terms of training, it's really key. Sounds in the hospital, touch in the hospital, all those things. The key there is really understanding the person, the patient, or the child, who's understanding their history, really getting to know, because that history is specific to that individual. And so that's really important for how you care for an individual. I'm going to go, thank you. Let's see. So what does trauma do in terms of this relationship, right? So if all things are going well in the world of development, and you get to go and, if you're in preschool, you get to be with your friends and you're on the playground and, you're climbing up the seesaw and you're doing on the swing and all that's going well. And then you get little peer interaction. Someone wants to play something you're playing with, so that needs to be mediated. Then that swings down. The teacher comes and helps and organize and helps problem solve, and then everyone's best friends again. So that you can just see that's all going well. Well, what trauma does, it interferes with this, right? It doesn't allow the child to freely explore, because the child has an experience of threat. So they're looking for danger. They're hypervigilant. They can't quite get to the delight in me part. They're going to stay down here. They need comfort. They need reassurance. So whether you're top or bottom is going to have a lot to do with kind of your experience. So in the hospital, some basics, which are always helpful, clinic as well. When trauma is triggered, it's usually you've got three options, fight, freeze, or fight, flight, or freeze, right? Fight or run away. And that just looks different depending on your age. But those are options when it's triggered, and it bypasses your thought process. And so that's going to look all different ways, but really important in terms of understanding what to look for and what's being communicated through behavior. There's a lot of miscuing behavior. The person might be threatening you, cursing you out, when they really need you to organize their feelings and provide safety and comfort for them. But it looks like that's not happening. It looks like they want to attack you, but really it's a miscue. So if you don't have that background, then you think I'm under attack and we got to do something. I mean, obviously you have to do something and keep everyone safe. But what the underlying need there is what's important to think about. Let's see. I'm just going to do. I think what I want to just appreciate here is what trauma. When someone's carrying trauma into the clinic, into the hospital, into your classroom, into the workplace, that it'll show. That it will show. There'll be a stressor at some point, and that will come forward. So this is in a classroom. So I would just say maybe an example is the playground free fall. So Janice running on a playground, the wonderful equipment, like a little climbing equipment. It's great. Slide down the tunnel. Except Janice, in this case, missed the part of the tunnel and came and landed, then, came out of the protective area on the climbing equipment and fell literally and face down onto the earth. Right. The 4 team members who were out there couldn't get to her in time, and everyone jumped because there was a thud, audible thud when she hit the ground. Right. So what happens? Janice didn't move. She didn't cry. She didn't look for help. So when you go and learn Janice's history, she had an experience of being abused in such a way where over periods of time. So her experience is when you're hurt, no one's coming. And in fact, it's safer to be quiet. Right? So now she's not thinking this, right? This is automatic process, right? This level of pain, don't move. Right? So that's really adaptive in a certain environment. But on a playground and with your friends and the teachers, that's not going to help. So obviously the team was there to take care of her right away. And then part of the work is really helping her talk about how safe she is in being able to express her needs. So that's also a really important part of the work. This is circle time, right? So you think circle time, you think, right, like when you're in class as an adult, but when you're preschoolers, you're in circle time. So you're reading the story and you're hearing what your friends are doing on the weekend. You're talking about feelings. Well, some kids are thinking about this stuff. So you have all these knives and there's a person under all the knives. And then you have a person shooting, and then you have the person has died and now they're covered in the grave. That's what's in some people's minds, some people's experiences. And so that attunement that we saw in the very beginning, the emotional attunement, is really important because we know people carry these experiences and there's different ways that get triggered. And so part of us designing a system of care is how do we aware what's in our mind is not in another's mind, right? And so that's really important, and that a lot of the people who are coming into care have adverse experiences that are going to need us to be more aware, and so we can support. And that's what happened in the classroom. Teacher got over, did a lot of processing around this, and over a couple days actually, and was able to really participate in circle. So when is a smile not a smile? Right? We are all wonderful people, right? We do good. We do good. People, I used to smile all the time. People would say, Jimmy, why are you smiling? Like in high school and things like that. We can't even know why you're smiling. So, well, I worked with a kiddo who was a young teenager, and he was in a situation where something went horribly wrong, and he injured in a profound way one of his siblings, a way that you could not take back. And so we were working together. So I had that smile. I had a smile. I'm thinking, oh, you're a nice therapist, doing good here. There's a really serious situation. But my smile reminded him of his sister, who used to tease him mercilessly with that smile, which was one of the triggers that led to what happened. So here I am thinking I'm a wonderful person. I'm going to show up. I'm going to bring my smile forward, and as a way of helping support the therapeutic. And in fact, the opposite was happening. So I had to learn, and that comes back right to that still face experiment, right? Be attuned. Like the smile's not getting the same reaction. So that's really helpful in terms of, really crucial actually, in terms of our training, is we're the instrument, but really it's how we present, and then how are we understanding the experience of the person that we're interacting with. What does it do? How are they responding to that? What are they showing us? And so this is just the idea of perceived threat. I mean, trauma is threat. That's if you want to take away one kind of thing, threat. And so we think of healthcare and institutions as safe, wonderful places, but that may not be the case. And when Dr. Buckles and I we had the opportunity to be in Haiti and walk with folks in Haiti after the earthquake, 2011. And this is one of the things they talk about is the places, the churches, the homes, the grocery store, those places that were always safe became actually what actually took people's lives. So the maximal threat. Right? So how do you rebuild the architecture? So Haiti had to rebuild physical architecture. And what we're talking about here is with trauma is how do we build emotional architecture to overcome trauma? And that's the good news, is that we know how to do it, is we provide supportive, nurturing relationships who helps the person calm down and helps them try and again and explore new ways of being in the world. Okay, I'm going to finish up. I think that's a really good spot to finish up there. Perfect. Okay, and so I'm going to pass it over to my wonderful colleague, who's going to then lean us in a direction that, again, keeps us focused on our healthcare workforce.
Thank you, Jimmy. Okay, now how do I get to my slides? Right there. It's not a touch screen now. Okay. No, not yet. Let's try that again. Okay, you want to help me with this, Grace, so I can. Oh, right there, that one. Okay, I need to go back. Thank you. Okay, so I'm going to shift a bit to talk about our responsibility as the healthcare providers in supporting others. We have to start by supporting ourselves. So yesterday afternoon, I had 144 slides. I now have about 30. So it is a lot to address. I'm not up closer. All right. So I'm not going to get into ACEs. You've probably all studied ACEs. There's one point I do want to make. We talk about adversity is not destiny, because it can be resolved. And so I highlighted the last part, resilience in the body can heal. We used to think years ago that you were born with a certain amount of resiliency, and if you didn't have enough, then that's it. That's all you're going to get. Things could happen, and that's really too bad. We know better now. We know that the brain is plastic. We know that there are resources and ways that we can engage with people to support their healing. And that's what Jimmy was talking about too. I want to start with something that I might come back to, but it's that stress curve. We all hear about stress, and we'll transition to the idea of trauma. You know, some stress is good. It gets you out of the bed in the morning. It helps you to do things you know you need to do. And if you don't do them, more stress could happen. But we also know that things can break down when there's too much. And I'll come back to that as well. Now, Jimmy gave a definition of trauma, so have I. It's when things have gone outside our normal experience. Our normal coping mechanisms no longer work. And what we've worked with in disaster zones is it's so much that all the ways that people have learned to cope in the past, which have been effective in supporting others and themselves, they're not there. They can try them, but they're not available to the extent that coping and support is needed. It's when, and I have seen this, I've actually experienced it in different disaster things where you see people like, they actually are hopeless because nothing is working for them that ever worked before. So what's the point? And they can become hopeless. So the individual usually has seen or experienced something that's life-threatening, that goes, as I said, beyond what other experience they've had, and that would include vicarious trauma. So when we think about trauma, and I am shifting to think about professionals too, but we think of things being, we call them in our own little vernacular, the big T, the little t, and the cumulative trauma. So the big T could be war. It could be, something horrific that we couldn't imagine as humans ever seeing an event like that. A little t could be something that you or I think, going to the dentist isn't such a big deal. For somebody else, it is a bigger T than someone else. A dog bite might be a little T for somebody, but it's a big T for somebody else. Then we think about the cumulative stress response, which is maybe too much, too long, or too little, too long. So you think about racism, poverty, deprivation, the things that happen with kids who have been placed in foster care. They may have had too much and they may have had too little. So it can be both over periods of time. And certainly issues of social injustice, observing it, experiencing it, are also aspects of experiencing trauma. Okay, it's not moving. Let's try it this way. There. So we know that we live in environments, especially if you have chosen a career in any of the helping professions, where you're going to run into traumatic situations. And it seems to be more and more than ever before, especially since we have seen and witnessed what a pandemic can do also. So we have those direct trauma experiences where we can have an acute stress response, which can go on for a period of time. And it usually resolves itself because we have adaptive experiences that we all engage in and support each other in. But we can also, and I've had this after being in a war zone, post-traumatic stress symptoms may not have progressed all the way to PTSD without diagnosis, but symptoms that can be nightmares, freeze responses, various other things. We do know now, and there's a lot of literature out there now, that the pandemic caused what we have is repeated critical incident stress, which leads to what we now think of as moral injury. Now, historically, I'm a social worker. So historically, I always thought, now, wait a minute, moral injury only should be used when you're talking about torture victims. That's really not the case anymore. There are some additional definitions that we have to realize. And moral injury for healthcare professionals can be things like, and we won't read the literature today, but too much, too long. Well, what about too little? Well, too little can be all the things that I've learned to do to help others don't seem to be enough. I seem to be doing too little. I have not the capacity to support in the way that I believe I was meant to support people and save lives. So it may feel like I'm unable to do enough. So too little. And we certainly have indirect exposure, different things that we hear about, see. Some of the research suggests that those who are not frontline workers may be more victimized by or more exposed to the indirects, the hearing of it, not necessarily the doing of it. They haven't necessarily been prepared for the same level of interaction as a part of their training. So they have a pretty high incidence of potentially having a vicarious trauma, even though you think, well, that's kind of like, doesn't make sense, but they aren't prepared to address it in the same ways of self-care. Let's see there. So what's the difference between traumatic stress and vicarious traumatization? Not much. It's how we experience things. And if you look at the two sides, a little bit different language is used, but it really is pretty much the same things. Perception is key. And we keep coming back to that. I may be in an event and think, it's no big deal. We were in the Ivory Coast and had bayonets at night pointed at us, and it got very threatening. I experienced it as very threatening. Others in our group were like, no big deal. It was fine. It ended up just fine. It's like, what was just fine about that? That was terrifying. But I saw it differently. Somebody might see a near accident and think, oh my gosh, I can't stop thinking about it. Someone else would be, it resolved itself. It's fine. No one was hurt. So our perception really is key. So when we talk about, and I really do mean us to talk about care for ourselves first, and we'll get to that more, but vicarious trauma, how does it affect us? And Jimmy was talking about this too. In all aspects of who we are, it could affect us. And again, you'll get these slides, I believe. So you can read the details for yourself. But this is another way of thinking about how each of these categories might express themselves differently in different people. And now my favorite statement that we make when we go internationally, these are all normal reactions to abnormal events. That's really key, even for ourselves. When we recognize that we're having a reaction, it's a normal response that we're having to something abnormal or overwhelming or too much or too little that we've experienced. And to recognize that doesn't make us necessarily weak, that makes us human and normal. What we find when we go into disaster zones or war zones, and people say, I'm having all these experiences. I used to be able to do all these things. I could do math. I could do all this stuff, and I can't do any of it right now. I've lost my mind. No, actually, you're having a normal, it might be a big reaction, but it's a normal reaction to an abnormal event. Normalizing the reaction helps us to move towards doing something about it, because it is a way of supporting someone with some hope. You mean I'm not broken permanently? Right. This may also mitigate very briefly, very quickly. In some cases, it may not. But there are also interventions to support people, even if it doesn't mitigate very quickly. So how does that affect us in terms of our work and what we do? And we've probably all been there at some point where we perceive that, I'm not quite up to what I normally do. I'm walking a little slower. I'm not responding quite as fast. I'm tired. I may be forgetful. I get distracted. I think I said that already, but I'm just not the best that I normally am, or I don't perceive that I'm really where I'm at. It could affect morale, decrease confidence in the ability to do what I was meant to do. It could affect relationships. One of the things that was projected after COVID, and we're in the 3-year long haul now, it may even be longer than that, depending on the intensity of events, it can last, is that coworkers, and we see it sometimes with students and others, the stress is lingering. They can act out, and they will say things they might not have said before. One of the things that was predicted is expect some broken equipment, some slamming of some doors and some things that normally a person wouldn't do, but they don't have the resiliency. They don't have the reserves that they had before. So it can affect relationships, and it can be obviously expressed in behavioral ways. Some of the examples that I just gave and that are on there, forgetfulness, poor follow through, or other kinds of things. So there are some increased risk factors as professionals that we need to recognize. If we have a trauma history that's unresolved, we're at more risk for developing and experiencing more trauma as we go forward. Pre-existing mental health conditions, if somebody, for example, has an anxiety disorder, being around things that are provoking that without the right supports and continuity of care for self, yeah, that's going to be something that could take place. What does it mean to be young age? Well, through life, we have experiences that teach us to cope. And if somebody has never had any of those, I pity the first big one they have, because it could really derail them. So they don't necessarily have life experiences. Some people have lived very protected lives. And so, yeah, they don't have any of the ways to draw on that they cope before, potentially. So yes, that could be a risk factor for someone. And when we think, these are professionals now, these are not children at young age, these are professionals without the experiences. So isolation, inadequate support. I'll talk about organizational support later on as kind of a closing. Something that has happened within the last 12 months that hasn't been resolved. So when we go out with the team, I'll ask questions. I ask them of myself and I ask them of others. So has anything big happened in the last 12 months? Sometimes it's a death in the family. It's like, then it's probably not a great idea for you to be on the front line dealing with death, because you're going to be thinking about someone else, not the people in front of you. Or illness and weakness, a body weakness because of an illness. Yeah, we're going to be really pushing ourselves hard. It's probably not the best idea for you to be right out there in the front lines, pushing yourself too soon. So those kinds of things, being aware of, and I'm going to say this again probably several times, but every behavioral health profession in our school, and I would assume in other professions as well, that I'm not familiar with all your codes of ethics, but every one of ours, psychology, marriage and family therapy, counseling, social work, they all have a component of self-care, self-management. So recognizing and having that dialogue with others and self is really critical. So the professional environmental things, lack of quality supervision, a high percentage of trauma survivors, and increased caseload. We think about this with like child welfare workers, really high workload, caseloads, and maybe not a lot of support, not enough time off the caseload to refresh and reflect. Again, little experience, mismatching, and lack of training, adequate training to the kinds of things that one will experience. So what we talk about, when you fly, they tell you to put your mask on first. Well, that's exactly what I'm telling all of us. When we're dealing with people who have been traumatized, and we know we're going to be dealing with people who've been traumatized, you've got to have your own mask on first. So you have to be dealing with your own trauma issues first. It's hard for us to admit weakness or that we are human and affected by the same things everybody else. But Jimmy, you said it. We all are. And most of us, and this is not in the slides, but like you said, most of us have had something. As humans, and I think in most cultures, we learn to push it down. What are the things you see on the comedy shows? Put some dirt on it, rub dirt on it, it'll be fine. Push it away, basically. Don't recognize it. It's no big deal. But as I've worked with colleagues and we've actually worked on what are the things that are hidden in there somewhere, when they bring them out and take a look at them, they're like, wow, I didn't think that was that stressful, but it's causing me to have a reaction to people whenever anything close to that comes up. I get triggered. I didn't know why I was so irritable every time those things would happen again. Yeah, it probably was bigger than you thought. So we bring it out and take care of it and put it aside. So whether it's therapy or wellness skills or other kinds of self-care, all of those are critical that we deal with ourselves first. So what are some of the impacts if we deal with vicarious resilience, working on ourselves then? So a greater perspective with an appreciation for our own issues and needs, being able to take time for those things when something does take place, recognizing, again, we're vulnerable to the human emotions, the impact, taking those moments as soon as possible, and obviously not in the middle of an emergency, but as soon as possible, to support ourselves and to support one another. And I'll talk a little bit more. Our team supports, we buddy systems, because sometimes you don't see it in yourself, but you can see it in somebody else. And it's okay to be available to support someone else, saying, you know, I need to take a break. Do you need a hug there? We need to help each other. Increased sense of hope and understanding. Being able to deal with this is a great aphrodisiac for burnout. It helps to get past it. So vicarious trauma can become vicarious transformation with the right support. I love that statement, and that's a fairly new reference. So Jimmy talked about the freeze response. We won't go into exactly what it is, but I am going to maybe need some help holding this thing. But we need to understand what it is. What is happening neurologically? The freeze response is the neurobiology of a survival response. And we all have it. We are divinely made. It's one of the most amazing things about us. You know, it's like, how do you think about that? I sometimes wonder, gee, Jesus really knew what he was doing when he made humans. Could you hold this for a moment? And I'm going to do this real quickly, and it's going to be primitive, what I'm going to do. So when we have an overwhelming experience, the bodies, we are meant to survive, and we hit the freeze response, whichever one it is, fight, freeze, flight, and then we have tend to befriend, which we won't talk about. That's a war zone type of thing. But this is my brain, half my brain. Okay, here's my brain stem. Okay, when you go into freeze response, this wonderful cognitive functioning in the frontal lobe, you don't need it. You don't need to do strategic planning at that moment. You don't call a committee. Your primitive brain takes charge. What do I got to do? The brain assesses the danger and decides what's the best course of action for you. To freeze, don't move, run, or fight. And you don't get to plan it. It's immediate. And so we tell people, you know, no shame. We don't go back and say, well, why did you do that? They don't know. That's what the brain is doing to survive. But people get stuck. Thank you. People get stuck. And so what we want to do as we work on reprocessing or wellness types of support after that is, what can we do so that that freeze response can be mitigated and you come back into the frontal lobe. The cortex goes back online. That's how we talk about it. So you're back into the good thinking place. You don't have to rely on staying there. So again, I can't get into this today, but we teach people about how the nervous system works. And what surprises me for all of us in healthcare, we talk about all the organs of the body, but not this one. And it's everywhere. And it affects all of us all the time. In pain, in resilience, and whatever. This is a big one. And learning how we respond to stress and how we calm from stress, and learning all the different component parts of the brain where memory of traumatic experiences are also stored is very important. Jimmy was mentioning language. And with language, what some of the research has shown when they've done MRIs is that in the, it'd be the amygdala hippocampus area where the memory of a traumatic event has been stored, there may not be language. With trauma reprocessing, and they do another scan, they can see that language is going into those areas. Those black holes start to fill with language because now they have words for what has taken place. And we know it's effective. It's one of the areas we're continuing to research in here. So let me just get all of these up. I didn't realize I had not taken all this out. So there's a perspective shift. You know, we started with a traditional conventional model where if something happened to somebody, what did you do wrong? You're a bad person. You must have done something wrong. Little kids don't do. Many times no one has done something bad, and something bad can take place. And then we've moved to trauma-informed, which we are still holding and trauma-informed, but we are shifting now to resiliency-informed. So we hear trauma and resiliency-informed. So people are suffering, what happened to you, but sometimes when we talk about just what happened to you, there's still that presence of shame. Shame is dangerous to healing. So we want to get past that to the strength perspective of resiliency. So basically, again, you can read all of this. What's right with you? What are your strengths? So a resiliency-informed care model, which is a transitional phrase that we've come through, probably it started about 10 years ago, but the actual real focus on it is only a few years old now. I have a slide on that. But it is an approach that focuses on building back resilience. It's actually a preventative too. There's an act that's coming out, hopefully gets passed. It's a Community Wellness Act that looks at early intervention, prevention, and taking away the stigma more and more of mental health, of much more public health, that we all have it, so we all need it. Preventative care is how do we infuse wellness in all of our lives. But when we're resilient, it gives us the ability to stay calm and be in control, even when faced with challenges, and to move back to our best place when something has happened. So again, there are benefits to this kind of component of care. It improves overall health, go back to the ACEs. It improves overall health and well-being and reduces the symptoms of trauma and helps us increase our resilience. I'm going fast, but this is a timeline, most recent timeline of moving towards the goals of having a more resiliency-informed care model.
So there are treatments for PTSD. World Health Organization endorses two of those primary.
Okay. I don't need it to record that. Okay, there, it won't say I've already recorded this once. So WHO does endorse EMDR, which is the eye movement desensitization, I can't say that word, reprocessing. So, and trauma-focused CBT. The challenges of those, because I mainly focus internationally with this, is the standard of practice is 12 to 15 weeks. In many places, the stigma of mental health is so high, you're not going to get anybody to go in for every week for that period of time. Now, hopefully professionals have access to that, and it is effective. It does work. So does trauma-focused CBT. Columbia University has worked with World Health to take that down to an 8-week model, but both of them do require professionals. EMDR is highly trained certification. It's expensive certification to receive. CBT is not, but both are effective. We've moved to a different model here that we're endorsing, and the first of it is and it is now evidence-based. It is a community resiliency model, or we call it CRIM. It supports both individuals and communities. It's very transformative. It's contagious in a good way, that people share the skills of wellness with each other very easily, from very little kids to older adults, and even individuals who may have impaired language. Because it's working with the nervous system, people can experience things. So we use that. There is a second model that we have not done clinical trials on yet, which is truly a clinician's model of trauma, TRM, the trauma resiliency model. Both of these were developed with the Trauma Resource Institute here in California that we contract with and support worldwide. They have 2 books out now that we've helped in the development of. And it's the Trauma Resource Institute, if you want to look that up and look at their books. This model is one we support here for professionals and patients here at Loma Linda. It's used to be everybody like, well, I don't want to do that. But now it's moving across the campus. We're moving it more and more into the student environment, because students certainly experience a lot of distress over time, and they bring a lot of distress with them many times that they didn't realize was all there until they tried to get a graduate degree and do 40 hours a week of everything and then 40 hours of something more. So there are 6 wellness skills. We typically, and I'm only going to talk about some of them, we typically focus on the first 3, and these are very effective for any health professional. As I've learned these, and one of the things that surprised me, the more I learned them, I will say, guilty, that in the past, many years ago, if somebody walked by me in the morning and said, "How you doing?" "Fine," I'd be just walking on. And now I've actually had the experience where somebody says, "Fine," but I see a slight something different, a twitch, a turn, something that's like, "Really? Are you sure?" And they're like, "No, not really. I'm not okay." Because I can track, I can see it to where I couldn't see it before because I've become much more sensitive to very slight changes in nervous system response. So let me just quickly go through this because we're going to run out of time. So we talk about a resilient zone that we all have, and that's where our nervous system is functioning at its best. Doesn't mean things aren't happening, but we can rock and roll through the day and it's not overwhelming. But as we know, let me get this all up. We don't need it all out there. When something big happens, we can get bumped out of that best place, that okay zone where we function at our best. We talk about getting stuck on high, where we'd be stuck in a primitive way of edgy, irritable triggers can easily affect us, hypervigilance. Now, sometimes we think of that stress zone that I had on that first slide. Stress seems to be too low. Nothing seems to bother the person. It may be that they've actually been bumped on low and are stuck there. And they seem like they don't care. Well, that apathy may be a stress response or trauma response, rather. That may be how they are demonstrating the trauma. Exhaustion, fatigue, apathy. And so it's not to say that we could just look at somebody and say, you just don't care about your job anymore, do you? It may be that something really has happened and we need to support them because they're frozen in a different way. And it can either way works. People do both. They can flip back and forth, or they can be predominant to one or the other. And that's the stuck on low. So our goal is to help people with these skills is to widen their resilience zone by learning to track their own nervous system and support themselves with various skills. They widen their resilience. Some people naturally have very narrow zones. Some people have very wide zones. If you ever met somebody, nothing ever bothers them. Truly never seems to bother them. They just bounce back all the time. Somebody else is like just the slightest thing and they're barking at people. It's like, wow, what can we do to not bug them? Well, they have a very, very narrow zone. So these skills would help to support people. We've had amazing stories of working with child soldiers where they didn't realize until they learned the skills that the beating of their kids, their kids in their classroom, probably wasn't the best way to have kids learn, because kids know I'm not going to ask a question. I'm going to get smacked. One child soldier we worked with in Sierra Leone, he said that about what was happening at his school. He changed that behavior. His kids started thriving. And then he realized he'd been beating his wife and children too, and they were afraid to come near him. And as he started using these skills to track himself, to know how he was starting to get triggered, and when a trigger would hit, he could set it aside and use a wellness skill instead of just having it blow up on him and then attacking others. So now his kids and wife aren't afraid of it, and they have a whole different family relationship. So tracking is learning to notice what's happening in the nervous system, becoming aware of what's going on the inside, and being able to address it with another skill set. I wish I had the time to go through all this with you, but we then also recognize how these biological responses, the releases of the stress, take place, and learning to stay with the good and move away from those things which are not positive. And so this gives you some ideas of wellness sensations too. Those can really surprise people when they've never experienced wellness sensations before. I've worked with a woman who had a lifelong of abuse, and she goes, is this what it feels like to feel good? Like, yeah, I'm smiling on the inside. Am I smiling on the outside? Yes. She goes, oh my gosh, that feels really, really good, because the trauma experience was something she carried all the time. So another one is the resourcing. Now, spiritual resources, we have internal, external resources, all kinds of things that bring us a sense of peacefulness, joy. The bigger the reaction to them, the better they are. But they support us in being able to even just to think about it. The body and the mind are connected. So if I think about something extremely positive and learn how to track it in my body, I actually can experience that wellness sensation again. And I don't even have to do the thing. I don't have to be in the place or with the people. I can think of it. So the voice of a little child talking to you or giggling makes you smile, doesn't it? If you think about what that sounds like. And it's different for every person. So we never tell anyone what their resources are. It has to be personal and unique, and it has to support the person. And we teach them to intensify it. Now, here's a few things where this transitions to helping others as well. is that after a crisis, a lot of times people want to tell the story, and that just takes them right deep into it. You can see them start to shake and cry because they're reliving it. You can actually see them trying to disassociate, looking back in there as if they're looking back at a memory and glassing over. So what we do is, because people start that long story, it's also part of resiliency pause. We say, well, tell me at what moment you knew you were going to be okay. Tell me when help arrived. And it takes them to the fact they survived instead of going all the way through they didn't survive. We've worked with individuals who don't know they've actually survived yet because they just keep replaying. Who has helped you the most? Who is helping you the most now? And again, tell me the moment that you knew you survived and when you knew it would be over. Let's talk about that point and then see how that sensation. My favorite to say to someone is, who or what is helping you the most right now, or what would help you the most right now? And when we worked with population here at Loma Linda, sickle cell population, there's a lot of difficulty there in terms of when they are asking for help. What would it feel like if someone said to you, what would help you the most right now? Instead of, what do you want? Or saying no, what would help you the most right now? That empathetic caring immediately starts to transfer. Oh, I'm here to support you. What would help you the most right now? There's several of these kinds of things that we say. And also in times of loss, can you tell me some of the meaningful memories? What did you like to do together? Sometimes we think it's disrespectful to start talking to somebody right after a loss, but they're thinking about these things already. So you're not actually intruding into an area that they haven't already started moving into themselves. Sometimes, an individual may start thinking of a resource or something that actually can flip on them, because especially if you're talking about abuse situations where, my mom's my resource, but my mom's the one who did the bad things. And so those things can flip on individuals. We also use, and this is, okay, thank you, grounding. Now, grounding is something, it's simple. And if you've ever been around somebody who's freezing or disassociating, this is a real simple thing to do, is we bring their attention to the fact that they're here and now. Their feet are firmly on the floor. They can sense the chair supporting them. They can sense the hardness of a wall. When we've been in earthquake zones and the ground is still kind of doing this, may I? I'm here with you right now. Right now, safe. Can you sense the fact that I'm here? Yes. I've had a patient be disassociated in a full freeze response, couldn't straighten up, fully bent over. And with her permission, I said, can you feel my hand? Can you feel my fingers? Now, as you can, just push back. Just push to my fingers. And she pushed back and she was sitting up. And then now what do you see? Well, I can see other things. Okay. So she could bring herself back to the present moment with some support of recognizing the here and the now. So I love to do this when I'm driving in California. You get in a traffic jam, it's like, oh, I'm late. Okay, I'm going to ground myself in this very comfortable front seat. I can sense the seat. I can sense the coolness of the air. I'm okay. It's fine. Nothing bad is happening, even though I'm stuck in traffic. So there are ways to ground ourselves. And I mentioned the resiliency pause again. Who's helping you the most now? We don't want people to talk over and over and over. I mean, that's kind of how, if they want to talk as much or as little, but if they don't want to do it, and I remember that happened to us in Haiti. People were trying to force individuals, tell us what happened. Tell us what happened again. Tell us what happened. It's like, they're like, I don't want to. It hurts. It was awful. Okay, you don't have to tell us as much. Tell us, what have you been doing to support yourself? What's making a difference now? And then they may want to tell you more later on when it's safe to talk about things. And the same goes for ourselves too. We also have help now skills that we use, and I'll give you the picture for the app. I mean, this works. We've been doing a lot of research on this, and these things really work fast. we have case evidence or data that shows individuals quickly moving from clinical levels of depression, anxiety, symptoms of PTSD, all three, moving very quickly to sublevels within days because of using these skills to support the nervous system coming back online. So help now can be, and these have to be culturally appropriate because some things you might do in one culture might not fit another. In some cultures, if you give a drink of water, cool water, it means you're going to tell them somebody died. You don't want to do that. You want to know what are the things that support people as emergency supports. But even now in my office, if there's something like, I'm in a funk. Why don't I want to do this? Something's triggering me about this thing I have to do. I'll go get a cool drink of water and just notice the sensation of the water going down my throat, and it resets the nervous system that fast. Or I'll get up and the nurses tell us they do this. They, we have the squares in the hospital, the carpet squares. They'll walk and count the squares, or they'll count something, and it distracts, and it brings them back to the present moment. So there's a whole variety of help now skills that we use also with patients. When they're very dysregulated and acting in a way that it's really overwhelming for them too, and little kids too. What are the colors in the room? How many colors can we all count? Or how many of those lights are there? Let's count them together. Or something like that to bring someone back to a place that's better and feels better. And there's the iChill app. And just very quickly, this care for vicarious very vicarious trauma and resiliency is more than just a personal responsibility. It's not just you by yourself. It really is an organizational responsibility for us all to be thinking about that. How do we support each other? How do we support the downtimes? How do we help individuals to have easier access to the self-care? How do we teach administration to do the things and supervisors to do the things that are really important? There's a whole other lecture on administrative abandonment that becomes critical in high stress environments. Criticizing people too much when there's been too much happening can be really devastating to well-being. Recognizing that everybody's doing their best at the moment. If something really bad is happening and there could be results that can't be fixed, then of course somebody has to step in. We're not talking about that. But my grandmother always used to say when there were too many girls in the kitchen trying to fight over how to make a cake, it's going to be a cake at the end. There's lots of ways to make the cake. Stop fighting about it. What goes in next? So if it isn't irreversible damage, then supporting people to do their best. There was a situation once in a country where mass death took place and they had no resources. One of the first responders said, I hope I did something okay. He said, I didn't know what else to do. I took the bodies, I built a kind of a barricade of these drum barrels that we had, and I put a tarp over that. And I put all the bodies behind it. Was that okay? And he was looking at me and I thought, golly, that was awfully close to the trauma zone. And the decaying bodies could have been a problem. And I saw his eyes start to widen like she's going to tell me it was wrong. I said, you did the best you could. Absolutely. That was the best decision. Oh, good. Because he thought, I really messed up, didn't I? No, you did the best you could. And that was the perfect decision to make at the time. Good for you. Because what would I have done? I don't know. He did the best with what was available to protect people from seeing the bodies. So it is organizational. What does resiliency look like? Yeah, you're taking away my 5 minutes. Oh, really? Well, I don't think so. We're going to give you time for questions. But what does it look like? It looks like strength and courage. It looks like gratitude and advocacy and forgiveness or hope. We had a situation in the Ivory Coast that I told you about, the night of the bayonets, and I didn't like it one bit. And I worked on resolving the memory of it. So it sits over there. It doesn't make me have a freeze response, or I don't go. People used to tell me when they would ask me again and again about it, it's like, you don't have any color in your face. I'm like, yeah, because you just asked me about the thing that bothers me the most. But now it sits over there and I can talk about it. What else does it mean for me? And I tell my students, it means I can be brave. I can go back out again And isn't that what we want this to support our workers with? You know, you are going to have some hard things to do, very hard things to do that you didn't probably want to do, didn't ever think you would do. But you can be brave, because even if it really affects you, we have skills now. We have ways to support one another and ourselves that can help us to continue to be brave and to bring hope and support to others as well. And so I think with that, we need to probably open it up to questions.
All right. Wow. I'm full. I am really full right now. So let's go ahead and open up to questions. Yes, we have a question here.
Friends a year and a half ago, and I would never have believed that I would have gotten my short-term memory back, joy back, time for my relationship at home, no longer on edge, no longer fearful of everything going wrong, able to go back into continue to work in a horrible COVID environment with many people who were terribly burned out, and just totally amazed at how wonderful my life is, with a great diet, energy, exercise, hope, and all the things that we really went through is what the group I've been we're working together. I've been studying for a year and a half, and then all of it, and we just started exploring because we were desperate. And so I'm actually also doing it with my palliative care team, going through the same books from the book club we started doing. So anybody thinking that this is not possible, that this isn't really true, it's 100% true.
And I think what you've also done too is just that it's just an extension of what we were discussing this morning about this sense of solidarity, and how in solidarity, you know, there is healing, there can be healing. Would any one of you like to comment on what he expressed?
I think it's amazing, and it couldn't have been easy to get people to participate, but good for you, because it is possible. I love that story.
And I think I heard in there the relational aspect, right? And so that, just to swing back, that is really, this all seats within relationships, that can help your nervous system calm, so that you can explore and you can try new things, and actually even reimagine that you could go back into a COVID environment, or environment that causes such stress. I mean, we ask teachers every day to go into classrooms where sometimes the kids get upset, overwhelmed, and they can harm the teacher, they can harm the friend. Right? They're in these classrooms every day, 211 days a year. Right? So it's why this is so. I mean, that's the learning that's shared. So wonderful that you could. Great timing.
Question? I have a question about workplace violence, and I'll just share a little bit of an experience I had where it was so I'm in the pediatric ICU, and we had a patient who was going to pass away, and the family was understandably distraught, but also reacting in a way that was I think everybody perceived it as very threatening. And so after this incident, there was a lot of training that went out about workplace violence, and there were tolerance policies that you could call, and you activate a security response, and you try to de-escalate, try to do all of these things. I'm wondering where in that algorithm, something like this fits in. I'm going to personally say I don't know whether I necessarily feel more safe. But I do notice a lot more parents being escorted out of their children's room with security, which, you know, and could be traumatizing for a lot of people.
Yeah. I'm going to try. It's not unusual. Let me just say that people get extremely upset when something like that's happening. And I don't have the perfect answer, but I can tell you one thing that happened in another country that one of the physicians there told us. He had gone through the training of the skill set of tracking and all these things. And it's like, okay. And we talked about how do you apply this in your world? Because we apply it a little differently in our world. And what he said was, so where he was at, not everyone was trained at the same level as they might be trained in the States in terms of putting a line in or something. And he had some individuals who were trying to put a line in, and there were like all these family members around, the parents too, getting visibly more and more upset every time it failed. And he was tracking, watching, and noticing a shift, just the slightest shift in the body tension of the parents and individuals. And that's when he intervened. He said, I went in, I knew exactly what to do to get the line in and to calm people down. And then there was pain relief because the whatever he was using. And then he could also make some affirming statements as to what else can I do to help you right now? And to just notice that he could bring down the tension. So each situation could be very different because, as Jimmy was saying, some people, we don't even know what their triggers are. We have no idea until it happens. And then being able to say, what can I do to help you right now? I think additional de-escalation application would be beneficial to everyone because I do think it's happening more and more. And really saying, what else can we do in a variety of different situations? Because the trigger could have already been hit.
Yeah, Grace, I mean, the other aspect of that is, I think what we talked about, like appreciating the stress that the families are under. Like we think we're providing care, right? That's our viewpoint. So people should work with us. They should be, grateful. They shouldn't get angry and be attacking us. But their experience is actually different. And they're seeing the level of stress in their loved one go up, or if the loved one's at risk, literally passing away, then the understanding that their level of stress may now be going to a point where they're not able to cope safely. Then how do you have a system in place that can respond to that isn't an over response, but certainly has to protect the workforce? I mean, and of course we're seeing that in the news more and more, the threat to the workforce directly.
I applaud all the healthcare providers here because what I heard being on this side of campus, not the other, were when we were in the midst of COVID, the daily reports of death. No time to rest between any event. Just being slammed one after the next. And I don't know that it's easy to even think about being available, but that's a whole new world now. How do we support each other when it's happening so fast, so much? And how do we support the patients who it's their one incident? Or maybe it's not. In the case of a number of my students, I have, in this past few years, sent out more flowers in 2 years than probably my whole lifetime. Condolences. That was my expense report every month. Flowers to the family, flowers to the family, flowers to the family, faculty, students, staff, over and over, and myself, everybody. One right after the next, and no time to recover between them. So how do we now make it much more of a priority to support ourselves, even if it's for a little bit, to intentionally support ourselves between these moments?
I've got a question. And it has to do with trauma-informed care education. So I went to nursing school. I'm a registered nurse, and I never learned any of this at all. I mean, it became very clear to me, Dr. Venza, when you were, beginning at childhood and how it just carries on and affects our behaviors as adults. Well, I also went to seminary and I pastored for 15 years. I never learned any of this in seminary. And so is there a movement now in our education systems that addresses this and helps individuals like nurses and doctors and pastors, leaders, understand the place of trauma and in the way that they lead and react and interact with individuals? I just would like to see if you have any thoughts on that.
We're changing in terms of our education and behavioral health because the melt rate of students is higher than it's ever been. It's usually been about 3%. It's 6 to 8% right now. It's like, wow. And it's not finances. You'd think, oh, expensive university, it's finances. It's overwhelming personal situations. I just can't do it. It's too much. And so, yes, but this is graduate education we're talking about. Why, if I had my way, why wouldn't it be for the little bitty kids and the families? Teach them early on because they can learn it. I mean, a colleague who we know who worked with us in Haiti's not here. She taught it to her toddler granddaughter how to find wellness and when she's having, instead of a tantrum in the grocery store, doing things that would calm her so she's not as prone to having a full-on tantrum because she's a little bitty kid without language yet, or now she has, but before even her language, teaching her how to calm herself. Why wouldn't we? There is one bill of community wellness that I mentioned that hopefully it gets passed. It's endorsed by all the major organizations, health care organizations, and it would bring it into a public health forefront that prevention, early intervention is where we need to start with mental health services because it does teach us about these things, about our bodies.
I think I mentioned the Maryland Commission on Trauma-Informed Care. So their states are more and more adopting aspects of this. I mean, SAMHSA definitely is leading the way. And I would also say that we have a really long way to go. Funding is right. So when you think of funding for kids, which is already way down from funding for adults, and then you think funding for mental health, keep going down, keep doing it. And then if you think funding for early childhood, you're at rock bottom, like not even 1%. So the prevention intervention model is flipped in terms of how dollars are utilized. Now, I think what you're highlighting is, but what's the model for adults too, and adult training, especially in hospital care? This is still a relatively new model. And, when you start talking like resiliency and thinking of people I think maybe you questioned that a little bit by saying, people kind of start to look the other way and, go to the next conversation. So I think part of it is why we appreciated Grace's introduction and inviting us to come is because we feel like this is a conversation that should be happening threaded through every conversation in terms of how healthcare decision making is taking place, because it in fact is impacting the bottom line, right? That trauma, because of the nature of trauma and how it brings people to the hospital at their sickest, and if you just treat without treating the trauma, you're just treating one part of it, and the expense is going to stay. So then that's the other way in terms of if there's a way to have that message clear enough so that funding can specifically integrate this type of model of training, that would be hopefully what's coming in the months and years to come.
Do we have any? We have a question back there. Do you need the mic, or can you project?
And chaplain, many times we meet people on the worst day of their life, and that can happen for us several times, and sometimes many times a day. Now, just being true to the topic, we're there for patients and families, and sometimes the family members are killed. And so my question is, because it could be an aspect of more dynamic in society that we try to shield certain parts of reality from children, but at the same time, we need to address their needs. So, what are ways that we can be with them and calm them and show dignity and respect to perhaps the loss of a loved one, while at the same time being sensitive to their own personal development?
Jimmy question.
Yeah. What a wonderful question, and so poignant and so just not on the radar, right? There's an amazing clinician, Linda Goldman, and she has several books about how to help grief and loss with children in particular, and how to give adults language for that. Because what you also see if adults aren't talking about that with their kids, what's happening, then it'll come out in behavior. It'll come out in anxiety. It'll come out in, quote, acting out, which we really try to reframe. That's just an emotional expression, a behavioral expression of what the stress level that the kid is under. So it's Reg Laurie would say that's communicating. The kid's communicating that they need support. So I think that there's a couple concrete resources like that. But I think one of the things that we've heard, actually, President Biden's the First Lady, so Jill Biden, she once was at a Laurie Center event supporting children's mental health, and what she said, which I think for parents you'll resonate with this, is that the family's only as regulated as the least regulated child. Okay? So everything can be wonderful with all the kids, but if one kid is really struggling, that's affecting the whole system. And it's also, a sign that things aren't right for the system itself. It's not like everyone else is doing great. It's a symptom. It's a symptom to say, listen, we need a kind of a bigger support for the family, everyone involved. I think I just also want to just appreciate you and the chaplains and the team. I'm going to just call out Denny, because Denny and I had an experience. We worked together. We had a death in the Laurie Center family. One of our teachers died. Was at work one day. Next day was, where are they? We're expecting them at work, and they passed. So we had a team of 60 people who were, in a state of shock of their team member. And so we met with the team, and we had a morning with them. But each of those team members had different experiences in their own lives. And this is where it is specific to the family. It's specific to each sibling in the family. So I think I'm just going to wrap this part of it by saying it's not that the parents, you just tell them to talk to the kids in the same way, right? It's not just let's talk to kids. It's like, let's understand what that child needs. What is the child? What kind of support does that particular child need? Listening to the child, asking the child questions to understand how they're thinking about it, because they're going to be thinking about it sometimes a lot different than maybe the adults initially think. And that way, then that leads, follow the child's lead. That helps you then design how you support.
And that applies for adults too, right?
Yeah, with adults, and adolescents are little adults, young adults. one of the things, so my experience is more with adults, is that, humans can hold two emotions at once. We're the only species we know of that can do that. You can hold grief and joy at the same time, which is kind of a shock to think, what? Yes, you do it when you grieve. So, and if you've been through grieving, then you know that at some point you're celebrating the memory of the person, you're laughing and talking, and then you're crying. And what we tell individuals to do is to recognize that when the one weight gets too heavy, the sadness, lift up the joy. And just recognize and track that you can shift it and stay with a wellness skill like the joy, the memory, and you will cry. That's a natural release. It is another God-given divine release of stress. It's okay. We don't tell people stop that. There's enough of that. I can't stand it. No, let them. And then they'll move back and forth. But the sadness and the negative part can pull them pretty far down, and they could lift themselves back up.
Awesome. Do we have any? Yes. Judith, and then this young lady here.
Hi. Thank you for the presentation. I do work as the CP supervisor, which I do work with religious workers, and we do a lot of good work. And I'm looking at safe places, the creation of safe places and safe people. And I'm wondering, when the space is no longer safe, what do we do? In terms of people, what do we do? Where do we move from there? And the group cannot be dissolved.
Wow. I don't want to oversimplify an answer because I don't know what has made it unsafe. And so you don't have to answer that, but I would say that's a key. What made it unsafe? Can that be turned around to recreate an environment that once again becomes safe?
A theme we haven't highlighted, but which is really threaded throughout, is rupture repair. Comes more from the therapeutic model, but that all this has a rupture repair aspect to it. There, it's not like everything's, you just build on it, it's going great. We keep building resiliency more and more. There's a lot of when you take two steps forward and then this huge kind of pushback is what feels like going backwards, and that's a play of the forces, and that's natural in terms of development. Actually,
it's not a question, it's a comment. Going back to your comment of the lack of communication. So there's this, I just came across this organization because I was offered a possibility of being in this class. And the organization is called the National Council for Mental Health. And they have put out this mental health first aid classes. If you're familiar, I thought it was wonderful because we're not resolving the problem, but we're creating more education, more awareness on how to assess when a mental health event is happening, how to de-escalate, and then how to refer. Yeah. So the three things, three band-aids right there, or one band-aid before you have to. And I thought it was wonderful. So I am in Adventist Health in Florida. So we're trying to see getting out the funds and the organization to help us so we can put pastors in our community through it, churches through it, and just kind of spread more and more, just to give that education, that awareness. But I believe you're all aware of that organization.
Yeah, that is wonderful.
There's also an online program that shared with us Indian Health called Living Works. We call it something else, but it's an online 90 minutes. It's very good. It's really focused on certified prevention and intervention.
That's a lot shorter. This
is a lot
all
shorter.
day.
Yeah, this is
a full day. Right.
Yeah.
Right. So we've got exactly a minute and a half left, well, maybe 2 minutes left. And so as do we have any more questions here? Oh, yes.
Please use the mic, otherwise the online participant won't be able to hear
us. Oh, thank you. Thank you. We have a question here.
I'm really curious, and I've learned recently about the MEND program. How does that connect to this conversation?
Okay, the MEND program, which the acronym is hard for me to remember, it is meeting each new direction. I think that's right. It is psychosocial intervention program for children and now also adults who have had severe chronic illness. So what we know about things like kids who've had kidney transplant, for example, that there are some pretty significant psychosocial factors that they can start to identify themselves as a patient for the rest of their life. And our MEN program, which was created in the School of Behavioral Health, address those chronic things to improve patient outcomes. I'll try to make this quick because it's a pretty remarkable. There are articles that have been written about it. So they monetize the behavioral health component as an integrated behavioral health to biological care, to medical care. And the results have been that it's sort of a flip of the outcomes. So prior to intervention, there would be, let's say the kids missed in 30 days, they missed most of the month of school. They might have attended a few days, but because of psychosocial and medical factors, most of the time, parents, same kind of thing. They were missing work most of the time to attend to medical care for their child. And the outcome with this, it's a family therapy, kind of a multimodal, different types of interventions depending on the needs of the family. It flips it. So now the kid might miss a few days a month, and the parents might miss a few days of work. The cost savings, I think, is something like $17,000 a year per patient. It's a huge savings. The biggest part for me, biggest takeaway, is prior to these interventions, the kid might see themselves as the illness. And because they have to take, anti-rejection drugs that change how they look and different kinds of things. So they're the sick kid. And now they're just the kid. They're just, and they have something they have to manage in their life, but they're just a kid. And so, yeah, it's a complete flip in terms of how they perceive themselves.
Hi, Google, can I find those articles?
Yes, you can.
All right, we've got 30 seconds. And so as we close, I would like you to give just one sentence. What is it that you want us to take away from your presentation? All right.
So one family, right? One family growing together. That's child, parent, professional. So we all have a different role at some point, and we can sometimes be different roles, different times. But it is that. It's the essential oneness and the unity of life.
Thanks, Jimmy. I would say self-care is not selfish. You're worth it. Give yourself the time and the opportunity to do it, even if it's hard to do.
Very nice. Thank you very much. Thank you very much. This is just a fascinating presentation. And thank you very much, everybody, for being here.